Thank you, Dr. Vijay. Thanks, the organizers. I think it's a bit disheartening to see only so many in the audience. I don't know how to complete this 30 minutes talk.
Sir, you're being watched online. It's being telecast online.
Okay.
So they're online attendees.
Okay. So we are going to discuss guideline-directed medical therapy, initiation and continuation. Everyone knows now the guidelines have become very crystallized in this management. So there is a little gray area related to the initiation and the continuation. So we'll see some aspects of those. Actually, we've gone through a lot in the last 2-3 years, and this is the stage. Even I reached this stage of "mujhe webinar nahi chahiye," and it's glad that at least some hybrid thing is happening. But we are still not out of this masking business, and we shall continue to do so for some more time. In heart failure management, in the late 90s, we realized that high sympathetic tone was a problem, and a drug which was totally contraindicated, beta blocker, became the drug of choice because sympathetic system was creating a havoc in heart failure people. The other system which was heightened was the RAS system, and if you could block that with the ACE inhibitor, and the olden trials are all related to ACE inhibitors, that brought in some benefit. Till about 10 years ago, it wasn't realized that this natriuretic peptide system gets enhanced or it gets suppressed in heart failure, and if you enhance it by some means or the other, probably you would get benefit in the heart failure treatment. So they tried with neprilysin inhibitors, but it did not work. So finally, they combined with a sacubitril, which is a neprilysin inhibitor, with a valsartan, the ARB, because the combination with ACE inhibitor was causing too much angioneurotic edema. So this combination finally worked, and it's now known as the ERNI. And ERNI has revolutionized the management of heart failure. Paradigm was a trial which brought in paradigm shift in the way we managed heart failure with reduced ejection fraction. And ERNI found a big foundation pillar in the management. Nowadays, in fact, what was a very disheartening disease to treat in the past has become a very rewarding disease, because we see patients who had ejection fraction of 30% now coming back with normal ejection fractions. We have patients who have gotten off the transplant list because their EFs have improved. And if you put the foundational therapy correctly, and if the patient has a disease like a cardiomyopathy, hypertensive heart disease, where there is no scar, the heart is not dead, they improve remarkably, like a puerperal cardiomyopathy. They can do very well with this kind of a treatment. And it is one of the rewarding diseases that we are treating nowadays. So the foundational therapy was ACE, ARB, and ERNI was one base. The MRA, that is spironolactone, and eplerenone group, that is a second base, because this is the only diuretic which brings in disease modification. It prevents the ventricular remodeling. Loop diuretics will give you symptom relief, but MRAs will give you long-term related to myocardial fibrosis. Beta blocker had anyway revolutionized in the past. The best mortality benefit in heart failure comes through beta blocker. So that would be always the first drug to start with, despite its limitation. And the new dapagliflozin heralded onto the scene with the DAPA-HF trial. It was a momentous victory in the war against heart failure. And if you put these 4 foundational treatments into management, you can do wonders to the patient. In fact, it almost works like a symphony, wherein all violins put together rather than a singular one make the things work very well. So if you give 1-year outpatient mortality and combinations of foundational medical therapy for heart failure, the red bar here is no treatment, only ACE inhibitor, beta blockers, ACE ARBs, and something else, only ARBs, and the foundational therapy. That brings in your best mortality benefit. So combination therapy is all 4 of them combine, then titrate them within a span of 3 to 4 weeks. You should have all the 4 drugs at the best possible doses. Initiate first and then titrate is what we are looking at nowadays. And now going beyond the guideline-directed therapy, the 2 drugs which are on the horizon, one is the vericiguat, which will be available in this week for management. This is for people who have worsening heart failure. Somebody had a admission or now going home after acute decompensated heart failure. That is where vericiguat comes into picture. And we always struggle with people with hypotension. That you can't start ARNI, you can't start beta blocker, you can't start too many diuretics. Then that is a drug which is omecaptive mecarbil, which is like a, let's say, modern day digitalis. It's also on the scene, but today the talk is on GDMT, so I'll restrict myself to the first foundational therapies. So if you have a HFrEF, that is reduced EF, you start with a ACE-ARB and a beta blocker, definitely. You can add a ivabradine to a great extent, a great advantage, because many a time beta blockers drop the blood pressure and the heart rate advantage is not achieved. So you are on a carvedilol 3.125 twice a day, but the heart rate is sitting on 84 and the blood pressure on 100. So you can't increase the carvedilol. So then you add a ivabradine, suddenly the heart rate becomes 60, 65, and there is a remarkable benefit related to that. So with or without beta blockers should be ivabradine. Then your MRAs, definitely. And then on the side, you have a rehabilitation, comorbid management like diabetes, fluid management, electrolyte management, and IV iron. I think this is one of the really changed major therapy in heart failure. Whether the patient is anemic or not, nowadays one has to send what is called as a iron profile rather than a lipid profile. Other than the lipid profile, you send an iron profile. And if you find that the ferritin levels are low, intravenous iron can bring about remarkable changes in them. So just once in 3 months, once in 6 months of IV iron makes a lot of difference. Oral iron doesn't work in this situation. So you have to give this specialized IV iron, which is, shall we say, has very little side effects and can be instituted very well in a smaller nursing homes as well. And other drugs will be isosorbate dinitrates. So when all this fails, then you go on to the ICDs, the CRTPs, the ECMOs, the left ventricular assist devices, and the transplant. But the GDMT is in the foundational 4, and as I said, dapagliflozin added to it. So the GDMT is a forefront in the management of heart failure patient. You can check only the yellow box. The key goals of GDMT is uptitration to target doses, introduction of newer therapies, and evidence-based approach to comorbidities. The ACC 2021 consensus recommendation is that GDMT is a foundation of heart failure care, and GDMT with the highest expected benefit should be prioritized, which all of us understand very well. The gray zone related to this was a patient who was getting discharged from the hospital. He has a hypotension, not many drugs are well tolerated, too many symptoms, but there are a lot of trials which were initiated right inside the hospital with a blood pressure of less than 85, less than 100, less 80, 90, all these were initiated. And now we are at a good post-discharge strategy wherein we know that if you have most of the drugs on board at the end of 1 week, if you initiate them inside the hospital, at the end of one month, they're more likely to be continuing, more likely to tolerate the medicine. There will be prescription which is honored. They're likely to adhere to the prescription and persist with it and feel better. All this can happen if you start the foundational pillars inside the hospital. And the best part is of the SGLT2, whether it can be started with the same dose, no titration required, 10 milligrams started and continued for heart failure management, whereas other doses would require a lot of adjustment to be done. So they are thinking, or we have been already instructed to change the sequence of events. For example, as I said, one would invariably start a beta blocker with or without ivabradine. And the second need not be ARNI. Second could be an SGLT2 inhibitor because it doesn't drop blood pressure. So the sequence doesn't have to be monotherapy, add, but start with a sequence of not hemodynamically disturbing drugs. And finally, at the end of 4 weeks, you should have up-titrated all the 4 foundational pillars. So the recent ACC 2021 consensus recommends initiation of GDMT as early as possible and to manage these heart failure patients in this manner. See, if you don't give the GDMT, that is lack of GDMT, it can have clinical outcomes which are very startling. You can see the curves. The yellow one is where the GDMT was offered, and the blue curve indicates too much events because the GDMT was not offered. The lack clearly shows higher risk of mortality, and this is the Indian patient studies from Kerala. Lack of GDMT was associated with increased risk of mortality in these patients. You can see the 2 curves clearly separating out. Lack of GDMT was associated with higher risk of hospitalization and emergency visits. Why everyone is harping on this heart failure hospitalization is because now a new drug which comes in cannot show great mortality benefit, because already the established therapy is so good that for a new drug in a short span, and legally you cannot do a trial without the existing GDMT. To show the benefit beyond that, the new drug has to do something else, and that is heart failure hospitalization. That is because 85% of the expenditure of a heart failure patient comes through hospitalizations abroad. Of course, we are figures abroad, but that could be true in India also. So major reduction in cost saving, and of course every hospitalization adds to the risk of mortality. And that's why any drug which reduces heart failure hospitalization, this is what ERNI did when it came in. This is what SGLT2 inhibitors are doing this way. And even the vericiguat, which is coming, also does the same, reducing the heart failure hospitalization. So the implications of continuing, we saw that if you don't give, patients are harmed. And if you don't continue, 35% increase in the risk of mortality in patient discontinuing GDMT. You feel, aha, patient's EF has improved. It was 25, now it's 45, his functional class improved. Then there is always a temptation to reduce the GDMT, especially because of the cost concern. But that is where this study comes into help, that if you reduce that or don't continue in the proper doses, you can increase the mortalities. Again, discontinuation of GDMT increase the risk of readmission for HFrEF patients. Discontinuation increases risk of all-cause mortality in post-hospital hospitalization patient. The figures are quite startling for you to see. In a nutshell, initiation and discontinuation of GDMT keeps the HFrEF patient alive and live longer, stands to reason because what we saw in the earlier slides today. So what is the GDMT which you could choose to initiate and continue? I have alluded to it already. The ESC 2021 guidelines recommend ERNI as a first-line cornerstone therapy for all HFrEF patients. As I said, based on the patient's hemodynamics, blood pressure, heart rate, these things can change. You don't have to be stickler of the sequence offered here. You are, if you are a good clinician, you will use all the 4 drugs to great advantage based on whatever sequence that comes to your mind best. And the new 2019 ESC guidelines have given 1A recommendation for the SGLT2 inhibitors. Same is true for the ACC-AH also. So we are now talking of 5 pillars of HFrEF management, whether there is diabetes or no diabetes. So first pillar would be ACE, ARB, or let's say ERNI, because hardly ever we are using plain ACE inhibitors or ARB these days. So it has to be ERNI to start with. Beta blockers with or without ivabradine. MRAs definitely. So your prescription may not include a loop diuretic, but must include a spironolactone or a eplerenone. I prefer spironolactone because it is cheaper. Eplerenone at least 10 times more expensive and has very little advantage of less gynecomastia. And of course, it has become imperative to use SGLT2 inhibitors, especially dapagliflozin, in reduced EF. In preserved EF, we are tending to use more empagliflozin. So there is initiation evidence related to ERNI as a first-line drug, brings in remarkable reduction in mortality, remarkable reduction in heart failure hospitalization, and fortunately now We have Indian data about which we can talk of. So 20% reduction in the risk of CV death with ERNI compared to enalapril, irrespective of the glycemic status. And this being a diabetic conference, I have to keep saying that I was actually quite reluctant to use the SGLT2 inhibitor in non-diabetics to start with, worried about hypoglycemia and other aspects, but I think it's quite safe. Now I'm quite a prolific user of these SGLT2 inhibitors. So the treatment definitely contains the 4 pillars which I was alluding to. And as long as the eGFR is above 25 to 30, you are safe. Because the heart failure with an eGFR of 30 will improve if you improve the heart failure. There is a lot of element of cardiorenal aspect. So rather than putting off by the eGFR, implement it in correct doses and you will find that eGFR improves because the heart failure is improved. So to summarize, go with the guidelines. Time is essential to start a guideline-directed medical therapy very early. Continue with ERNIs and other things with confidence, even if there is a borderline hypotension, eGFR low and other things. And there is funny thing related to level of evidence. I like this slide and usually end my talks with this slide. See, if you look at the top, there is mathematics. And at the bottom, there is philosophy, God, rebirth, karma. This is typical Indian stuff, emotional stuff we talk of. And if you put the evidences like that, it is 1A. Mathematics is still 2 plus 2 is still 4. And philosophy is 2D. So you can keep talking hours about philosophy because nobody can question you on that. But medicine that we practice is 2B. That means it is fluid. What we talked 5 years ago may not hold true today because the evidence keeps changing. And that is where I stand today. Today, I feel GDMT for heart failure has really established itself with phenomenal results. Putting the 4 pillars and the side therapies like IV iron becomes very important for the patient. And we've had patients who have done remarkably well, have become absolutely normal individuals after few months of therapy. So the conviction has to be there, the knowledge base has to be there, the information is there in the books, that has to get converted to knowledge, and finally wisdom will dawn on to us that if we implement it very well, we can do wonders to our patients. So I shall stop here. Thank you very much.